Thank you, Anne, for this introduction and the role of these new agents, how they were developed, and how they have been progressively integrating the field. So I think there are a couple of guidelines regarding the use of this agent and the way we manage patients with Hodgkin lymphoma. You remember that we basically segregate patients into different categories: limited stage favorable, limited stage intermediate, and advanced stage, limited with some adverse prognostic feature, bulk or others. We have the relapse disease, which usually, at least in younger patients, consists in salvage therapy followed by a transplant. And remember that about the post-transplant setting. And some salvage regimen are shown on this slide, although others have been developed. So those are summarized in ESMO guidelines, which I think when we read it was from 2018, so it's pretty old. So my colleagues from Europe, you should get to work back and develop new guidelines. And I think the NCCN guidelines were updated very recently to take into account some of the comments. So we will eventually refer to this guideline, but also to the expertise of our faculty today. So a few patients came to clinic in recent weeks or in recent years. And the first one was this 33-year-old gentleman having on the PET-CT an FDG-avid lower neck and supraclavicular adenopathy. The conglomerate show, lymph node of 6.4 by 4.1 centimeters, SUV 6.1. You can see the other details. And there was another anterior mediastinal adenopathy. So it was basically localized Hodgkin lymphoma, stage 2, no B symptoms, all labs were within normal range. And obviously it's an untreated, newly diagnosed patient with localized Hodgkin lymphoma. And the question here is which therapy will you select for this patient in the first line? So I encourage you to react quickly, because after that, I will ask to Anne and Paul what they will select. And you have the possibility to choose 2 cycles of ABVD followed by 20 gray radiation. Well, it's moving too fast. 4 cycles of ABVD without radiation, 2 cycles of ABVD, and if PET is negative, 1 additional cycle plus radiation, or 4 cycles of BVAVD and without radiation if the patient at the end of treatment is in PET-CR. So I think we see a couple of voters, which is good. And maybe ask Anne first to comment on this case.
So in early stage Hodgkin lymphoma in younger patients, my priority is to try to avoid radiotherapy if possible and use PET-directed use of radiation. So I would do 2 cycles of ABVD and then do a PET scan. And if the PET was negative, particularly if it was a DOVA 1 or 2, based on, we had an alliance study in the US using this strategy. The patients did very well with 4 cycles of ABVD only. Patients with DOVA 3 did a little bit worse. And if a patient, if he was PET2 positive, I would then incorporate radiation. I would continue with ABVD. I would not escalate to be a cup, as was done in the H10 and in this alliance study in the US, but would instead stay with ABVD and then assess response and incorporate radiation at the end. And fortunately, the PET2 negative for a patient like this is going to be on the order of 90%.
Paul.
Yeah, so I would say that my treatment recommendation would be based largely on the HD16 trial from our group, because this is the situation which we would judge as early stage favorable. It's very localized disease without any risk factors. And we know from HD10, which is very old, but I think very important trial, that we can reduce the number of ABVD cycles in those patients to just 2. and also reduce the radiotherapy dose from 30 to 20 gray. And that is something that is a very short, very effective treatment, which we recently confirmed to be also the case in long-term follow-up. So I don't really see a necessity to expose such a young patient to 4 cycles of ABVD if I can get away with only 2. This is especially important in light of the doxorubicin dose that is administered and given where the disease is, so left side of the neck and also upper part of the mediastinum. I wouldn't be too worried about 20 gray of irradiation if conducted with modern radiotherapy planning. Last but not least, the whole treatment can be done without any PET guidance because we would irradiate irrespective of the PET response, which is also what most people favor as the second most popular treatment in this case. And this is something that can then be also adapted in a resource-constrained setting, in my view.
Okay, so we have already a little debate regarding the role of radiation in localized Hodgkin lymphoma. I just tell you, because this is a real patient, that he actually received 2 cycles of ABVD, was PET negative, received another cycle and radiation. So it's probably my heritage from the Gilles RTC study. And we offered him actually to be without radiation. He was a young physician, and he decided to go for radiation. That was interesting. So I think maybe we go for the other cases. Just we have put the ground, or any comments regarding the cure rate of this patient, both of you? What do you estimate the cure rate of this patient with this strategy?
Maybe I mentioned the long-term follow-up of HD10, which to me is a benchmark. And we know that the 10-year PFS in those patients with 2 cycles of ABVD plus 20 gray radiotherapy is roughly 90%. So it is very good, I think, but it's still not as good as it might be if we would be able to incorporate novel targeted approaches also for these patients. And to be honest, those patients have been left behind a bit because everyone was focusing on advanced stage disease, and no one really conducted any pivotal trials in early stage favorable or unfavorable Hodgkin lymphoma, and we don't have any regulatory approvals in this context, and we will likely not have them, at least in the European or public health sector in the near future.
So I'd agree. I think 90% durable progression-free survival would be what I would be thinking for 4 cycles of ABVD. And we do have a study in the US, a very large study that's a collaboration between the pediatric and adult cooperative groups. It's going to take all early stage patients, divide them favorable, unfavorable based on the EORTC risk factors, and then standard of care based on H10. So this patient, if he were PET negative, would be randomized to receive 2 additional cycles of ABVD versus BV-Nivo for 4 cycles. And if the patient were PET positive, then would get escalated to be a CUP for 2 cycles plus radiation versus BV-Nivo plus radiation. So this is a very large study, 1,700 patients, but is accruing quickly because we've engaged our pediatric colleagues who are very, very good at putting patients on study.
One word. I mean, I offered that to the patient who was a man. I probably will have been a little bit in a different situation with a woman, and definitely will not recommend radiation therapy. Paul, any concern if this was a woman regarding radiation therapy?
Yeah, I think you have to be much more careful in actually assessing where the disease is localized, and if in this particular case, you have it in the left upper mediastinum, so you might have a considerable amount of breast tissue in the radiation field, and I would be openly discussing this with the patient, to be honest, and also try to avoid radiotherapy. If I would do so, I would largely do it based on the H10 data.
Okay, thank you. Okay, we are going to a case which is now a woman who was 30 years old, no significant past medical history, and she presented with a large mediastinal mass, 13 centimeters, with, essentially an interior mass, but also lymph nodes in the mammary chain, axillary nodes, no extranodal localization. So, and she had some B symptoms. She had already 1 child, and you can see the PET. And the question is roughly similarly the same, and we just changed a little bit the regimen. One proposal was 4 cycles of BV-AVD followed by involved radiation, 2 cycles for escalated BCOP followed by 2 cycles of escalated BCOP with PET after C2 is Deauville below 3, 4 to 6 cycles of PET-gated BRICAD followed, I have to follow the lines, plus 30 gray of radiation. And there should be something, which is a well-known study, 2 cycles of ABVD, followed if the PET is negative by 4 cycles of AVD. So I think it's interesting. We do see equilibrium between the different strategy. BVAVD was a local trial at Memorial, which addressed the treatment of some of these patients. Actually, there were different arms, and the last arms did not contain radiation. And this was published by my colleague Anita Kumar. But let's go there. And maybe this time I ask Paul how he will manage this patient.
Thanks. So in our world, basically, this would be considered advanced stage disease because we have the combination of B symptoms and a large mediastinal mass. And this is exactly the population that was also included in the HG21 trial. It only consisted, made up 10% of this trial, so a small subset. But we have historically been treating those patients as per advanced stage disease. And I would hence argue that we should also use the HG21 data to treat these patients, and this would be 4 to 6 cycles of PET-guided recut and only use radiotherapy to this mediastinal disease if in the end we have PET-positive residuals. So in my view, there's no need to radiate just because you have initially had bulky or large mediastinal mass, and we would try to tailor the amount of chemotherapy based on the interim PET, similar to the option that is also shown, which is the RATHL trial, basically.
So I would follow a RATHL approach. In the RATHL study for the patients who were PET2 negative and got 6 cycles of chemotherapy, only the PFS at 3 years, I believe, was 91%. We did a study in the US cooperative groups also with this using 6 cycles of ABVD in PET2 negative patients, and the outcomes were very good for patients who were PET positive. They got 4 cycles of escalated BACOT plus radiation, but about 75% of patients were PET2 negative. So I would, again, prioritize reducing radiation. I'd be worried about fertility with BRCAD. The doses, a third of patients will require 6 cycles of therapy. You can't figure out who those patients are up front. The cumulative dose of Cytoxan is 7,500 milligrams per meter squared, plus etoposide, plus dacarbazine. And if you look at FSH, it's really not going to tell you about fertility or egg quality. You've got to look at AMH. And a patient who's 30, is already getting towards older. If she wants to have a child in her later 30s after BRCAD, that's not going to be possible. She would need to pause and do fertility preservation. So I would stick with ABVD.
Maybe just 2 quick comments, if I
may.
may. So you would also consider this in advanced stage patients if you would follow a RATHL approach, which I think is totally fine to do. Why would you opt for RATHL and not for Nivo-AVD then in this case?
These patients were not included in Nivo-AVD. Yeah. It was only stage 3 and 4, and we've been pretty conservative about how we apply the data. But I agree, this patient would also be eligible for our early stage, that study that I just mentioned, and could get, RATHL would be the control arm in that study if she's PET2 negative, or would get BB-Nivo for 4 cycles.
And maybe just one quick comment on the fertility issue. I mean, we have shown this data at EHA for BRCAD, and we actually see a much better preserved gonadal function measured by several of the sexual hormones. Yeah. We have seen a normalized birth rate after BRCAD compared to age-matched general reference population after BRCAD. And this age effect that you mentioned, which is, I think, very crucial, above or below 30 years of age. Right. With BCAP, we don't see this anymore if we use BRCAD, and I will show this later again today.
Fantastic. So this brings us to a younger woman now, which is 20 years old, and a stage 4 disease. So this woman, as you can see, had a large mediastinal mass, but unfortunately also, I don't know if it's unfortunate, but that's another question. When we hear that, advanced localized and advanced stage are treated somewhere in a similar manner. Had also some lumbar lesions that you can see on this PET. And we are going to ask exactly the same question. And here it's a little bit different. So we have the trial with 6 cycles of ABVD plus escalation if PET2 is negative. We have the 6 cycles of BVAVD based on the US trial that was mentioned. We have the 4 cycles of BRCAD if the PET2 is negative, mentioned by Paul. We have the 6 cycles of Nivo-AVD. And I think I reviewed almost everything this time. It was a little bit less complicated. So the question, young woman, 20 years old, stage 4 disease, without these symptoms, 4 cycles of BRCAD versus 6 cycles of BV-AVD or 6 cycles of nivo-AVD. I think we will probably all agree that starting with the BVD escalating will be something from the past.
Yeah.
Great.
And
So I would give this patient nivo-AVD. This was exactly the kind of patient who did extremely well on the S1826 study. For the patients who were 12 to 17, the PFS was 95% at 2 years with nivo-AVD. She's a little older than that, but the outcomes were excellent at 92% with really very favorable toxicity profile and likely no impact on fertility.
Yeah, I mean, I'm very happy to see that not many people would start with ABVD and try to escalate based on PET2, because this is something that we know doesn't work in Hodgkin's lymphoma. If you want to cure these patients, and especially those higher risk situations, you need to get it right from the start. And to get it right from the start, we have adapted this, let's say, intensified approach from the first cycles onward. That's why I would again opt for HG21-based approach. Excuse me. And what could be considered is to basically, I think BRCAD is a very good option for this patients. I'm a bit puzzled to see 6 cycles of BV-AVD, because we have clearly seen that this is not superior, doesn't match to nivo-AVD anymore. I think this might also reflect accessibility of something like nivo-AVD in many settings, and I hope that we will be able to overcome this, actually, to be able to either use BRCAD if we feel we want to go for a PET-guided approach, or use nivo-AVD.
yeah, well, this patient was treated before the result of the I never remember the number of this study, but basically the US study. So you see BV-AVD. I hope my French colleagues are not upset that I don't show the AHL, which I can't remember the name, the numbers, which started with 2 cycles of escalated BCOP followed in PET negative by ABVD, which gave also excellent result, and followed this idea that we started with something higher. Can you recall us what will be the dose of anthracycline of 4 to 6 cycles of BRCAD?
So 1 cycle of BRCAD has 40 milligrams per meter square.
Okay.
So it's 160 for 4 cycles and 240 for 6 cycles, which is less than the 300 you get with nivo-AVD 6 cycles.
I will add that, so our pediatric colleagues always use dexrazoxane, which they believe pretty strongly, and apparently binds to topo2B and prevents cardiotoxicity in that manner. So we'll have a group of patients who were treated by adult oncologists, and the same age group is also treated by pediatric oncologists. So we'll get to see whether there is any difference in late effect with the use of dexrazoxane. I'll also add, we did a small study in the US adding atorvastatin to patients receiving anthracyclines, and there was a significant reduction in the risk of cardiotoxicity. So that's something that we routinely do in all of our patients. It has low toxicity.
I found this paper recently again by random for another purpose, and I was surprised because nobody talked about this study nowhere.
Yeah. Except at our place, because we participated. So we're a big believer. I mean, it's such a.
So did you adopt that in practice?
Yeah, we do it. We do it for everybody.
Okay, that's a little parenthesis.
Yeah.
Can you recall us a little bit the side effect? You mentioned that during your initial presentation, encounter with nivo-AVD. I remember a discussion with your colleagues, Paul, years ago, when you started the first combination of nivo-AVD in other patients, actually, that we will discuss later, regarding the risk of endocrine dysfunction in young patients and things like that. Can you recall a little bit this data?
Yeah, so in S1826, I think 9% of patients came off nivolumab for toxicity. And when you look at, the adverse events in this study were mostly thyroiditis, which we would anticipate and easily treat. But I agree. I mean, it's just unpredictable. And when you have a really horrendous immune checkpoint inhibitor related toxicity like type 1 diabetes or, myositis or myocarditis, it can be a very significant toxicity. Fortunately, they're very rare, but they can occur, and again, unpredictable. So you have to watch these patients carefully.
Yeah. Maybe I can just briefly comment on the whole heart failure issue, because I think that's something that we have neglected as a field a bit in lymphoma overall, because we use a lot of anthracyclines also in other non-Hodgkin's lymphomas, and there's also good data for ACE inhibitors, for example, to have cardioprotective effect. And I will be very interested to see whether those patients that you had received dexamethasone on the S1826 versus those who didn't have any different outcomes in the long run. And I'm pretty much encouraged to start using something like this as well in our patient group, to be honest. Yeah.
And I should say also, because we shifted from BV-AVD that became the standard at some point to Nivo-AVD when we were able to get the drug in the US a little bit earlier than even the full publications, that it's a marked difference in patients' quality of life. I mean, when you do that, the patients go straight through and don't have, some of the abdominal pain and other issues. Okay, we are facing also older patients. I remember there are patients that are young with Hodgkin lymphoma, but there are also patients in the 6th or 7th decade of life, and the management of those may change. And this is a woman who was 7 I can't read, but that's okay. And she had a couple of comorbidity, hypertension, hyperlipidemia, type 2 diabetes. She has prosthesis of the hips. She was working with a cane. Well, yeah, kind of a patient. And she had also coronary artery disease and treated with stents 10 years ago. And she presented with a 3A Hodgkin lymphoma, and she obviously is untreated. And now the question is, how will you manage this patient? Are you, she's 3A, are you going to go for a BVD and try to reduce the exposure to bleomycin, decreasing to AVD? Will you try to do this sequential approach, which is called 2 cycles of BV, 6 cycles of AVD, and consolidation with BV? Will you try to do 6 cycles of Nivo-AVD? I put PVAC because this was still in the recommendation of the ESMO. I have used that many, many years ago also, I should say. And then you have people eventually arguing that maybe BRICAT could be a regimen used in this patient. So,
yeah, maybe
Paul, go ahead.
Yeah, so here I think we are on the same page. I would prefer Nivo-AVD in these patients. I think the outcomes for older patients, especially in this 75, 80-year-old age group, are outstanding with Nivo-AVD. It's a really big step forward. I would just want to mention that these patients up to 75 years could be enrolled in HD21 older cohort. We have shown the data recently. We will again show an update at ASH. And it overall seems to be feasible. So if you wanted to somehow decrease exposure overall in a patient and pursue a PET-guided approach, especially if there's pre-existing cardiac disease, you might consider this for an older patient. In this particular case, I would definitely go for Nivo-AVD.
Yeah, agree. I would go with Nivo-AVD. There were only about 50 patients in each arm in S1826 because we knew from the Echelon 1 study that there was not a benefit of BV-AVD in patients over 60. I think the BV-AVD is particularly poorly tolerated in the very young patients who don't tolerate the growth factors, but also in the older patients. So the outcomes were really very good in that group.
So I think if you are following the press, I think the phase 2 studies that Alison Moskowitz conducted at our institution for this patient will be hot from the press in GCO very soon with Palari Torka as a first author, which was a phase 2 study. I just would like to point for those who are using a lot of PET to pay significant attention to the interpretation of PET in this series. We had a couple of patients that were PET positive at the end of treatment. The biopsy revealed to be negative. Some of these patients have stayed in CR. Some didn't have a biopsy and stayed in CR. So clearly the interpretation of PET-CT at the end of treatment in patients that were exposed to immune checkpoint needs to be much more carefully weighted. Okay, we'll go for one case in the relapse setting, which is a 25-year-old male. He had received ABVD, was found to be primary refractory. He received some salvage without any targeted therapy and came for transplant. So basically, early refractory disease for patients that were presented initially with quite adverse prognostic features. And he's in PET-CR after his transplant, and he comes to you and he says, well, is that enough? Do you have any recommendation? Will you potentially offer another treatment for me for consolidation. And you have the choice between sending this primary refractory patient to your colleague doing an allo transplant. You may want to irradiate this patient who has localized disease. You may think about PD-1 therapy, or others could be nothing, actually, and brentuximab vedotin. So I think there is a vast majority for brentuximab. Any further comment on the long term of the ITERA study?
It looks good. 60% of patients remain in remission. I think the toxicity of brentuximab in this setting is significant, and a lot of patients don't get to the full 16 doses. So I think you have to be pretty ready to dose reduce or terminate brentuximab early. We did do a study, a local study at Dana-Farber looking at PD-1 after auto transplant, and those outcomes looked really good, but obviously not compared to anything else, and not part of our practice at this point.
Yeah, I fully agree. I'm a big believer in brentuximab vedotin consolidation based on ETHERA, very strong data. We don't really know how applicable this is to a current landscape where those patients receive either brentuximab or PD-1 antibody in the first-line treatment. So I'm a bit hesitant to translate it into nowadays care. If they have not received this in first-line treatment, I would definitely go for it. And I would also expand the number of risk factors you take into consideration to consider a patient for consolidation beyond what was used in ETHERA, because we know from several studies that there are other risk factors which are prognostic for PFS and also overall survival in this situation. And these patients should actually be consolidated. Personally, I do 8 to 10 infusions usually. Otherwise, patients really develop neuropathy, and the added benefit fades towards the end of this year.
Yeah, I think we all agree with that. I think it remains a little bit at this time, and with the question of accessibility, a pity that this patient hasn't received immune checkpoint before in the salvage regimen, given the very high response rate. And I mean, some retrospective and collective data showing that integrating this agent within the salvage regimen clearly improves the outcome of patients with relapsed disease. Okay, Paul, you have to give the future perspective. Thank you all for this participation, and I hope this case had helped to inform you, regarding the management of patients in different places and the pros and cons of these strategies.